Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the valvular heart diseases of the cardiology, that is the tricuspid regurgitation. So, if you see some general considerations of tricuspid regurgitation, what is the definition of it? It is regurgitation of right ventricular blood into right atrium during regurgitation of right ventricular blood into right atrium during right ventricular systole is called as the tricuspid regurgitation. And this tricuspid regurgitation, it frequently occurs in patients with pulmonary or cardiac disease with pressure or volume overload on the right ventricle. So it usually occurs in patients with pulmonary or cardiac disease with pressure or volume overload on the right ventricle. Okay, so that is what is the etiology of the tricuspid regurgitation. And this tricuspid regurgitation from pacemaker lead placement, tricuspid regurgitation from pacemaker lead placement it is common, it is common. See, what is this pacemaker lead placement? You have single chamber pacemakers and you have dual chamber pacemakers. Single chamber pacemaker is that a single lead is placed directly into the right ventricle, and when the lead is being placed in the right ventricle, it has to pass through the tricuspid valve and then it has to enter into the right ventricle. And the presence of this particular lead, that makes incomplete closure of the tricuspid valve, and due to which there can be tricuspid valve regurgitation. And how will you diagnose this tricuspid regurgitation? That is mainly by your echocardiography. So echocardiography, it is useful in determining the cause of the tricuspid regurgitation. Now, what are the other etiologies which will cause the tricuspid valve regurgitation? Let me discuss the etiologies in detail now. See, this is the normal tricuspid valve, and you can see the tricuspid valve over here where it is dilated, and you can see the tricuspid valve cusps, you can see the tricuspid valve cusps, they are pushed into the right atrium. So this tricuspid valvular regurgitation often occurs whenever there is right ventricular dilatation from any cause. Okay, so whenever there is right ventricular dilatation from any cause, this can make the individual to develop tricuspid valve regurgitation. And please remember, as the tricuspid regurgitation increases, the right ventricular size increases. Right ventricular size increases. Okay. Further, pulling the valve open due to chordae and papillary muscle displacement. So you can observe that here. So, so please see here that the chordae it is pulled up during the right ventricular systole, and you can observe even the cusps, they are also pushed upwards. Okay, so as the tricuspid regurgitation increases, the right ventricular size increases, further pulling the valve open due to caudal and papillary muscle displacement. Okay, so whenever the right ventricular size increases, okay, and at the same time, what will happen to this chordae and as well as the papillary muscles, right, both of them, they can undergo displacement. Okay, that is what will happen in tricuspid regurgitation. So whenever the chordae and papillary muscle is displaced, that will cause tricuspid regurgitation. And as the right ventricular size is increasing, right, as the right ventricular size is increasing, the tricuspid regurgitation, it will further worsen, right, it will further worsen. Okay, so now why the right ventricular size is increasing, let me explain you. See, the blood from the right ventricle will enter into the right atrium during RV systole, and during the RV systole, the right atrium, it is receiving the SVC blood, it will receive the IVC blood, and it will receive the tricuspid regurgitant blood. So the quantity of the blood within the right atrium is more. So subsequently, when this entire blood is entering into the right ventricle, what will happen to the size of the right ventricle? The size of the right ventricle, it is abnormally dilated. Okay, so whenever the right ventricular size increases, that will further worsen the tricuspid regurgitation. Now you need to know what are the other causes of, right, you need to know what are the other causes of enlarged dilated right ventricle. Okay, it is actually enlarged dilated right ventricle which will cause the tricuspid regurgitation, and this enlarged dilated right ventricle may be present if there is right ventricular systolic hypertension. Right, when there is right ventricular systolic hypertension, and this right ventricular systolic hypertension, it could be due to valvular or subvalvular pulmonary valve stenosis. Right, it is due to valvular or subvalvular, right, it may be due to valvular or subvalvular pulmonary valve stenosis, right, or in fact the right ventricular systolic hypertension can be due to even pulmonary hypertension, right, even it can be due to pulmonary hypertension for any reason, right, and if there is pulmonary regurgitation secondary to pulmonary hypertension, even that will cause the dilatation of the right ventricle, or even in patients with the cardiomyopathy, right, even in patients with cardiomyopathy you have dilated right ventricle, and that can predispose the individual to develop tricuspid regurgitation, right, and this right ventricle, it may also be injured from a myocardial infarction. Right, it may be injured from myocardial infarction. Even that will cause the dilatation of the right ventricle, causing the tricuspid regurgitation. And whenever there is right ventricular injury, there can be rupture of your papillary muscle. And once the papillary muscle is displaced from the endocardium, the individual will develop the tricuspid regurgitation. Okay, and this right ventricular dilatation, right, this right ventricular dilatation, it often occurs secondary to left heart failure. Right, secondary to left heart failure. So these are all the causes of the enlarged, dilated right ventricle, and that can predispose the individual to develop tricuspid regurgitation. Now, apart from that, what are the other causes? So we also have some inherent abnormalities of the tricuspid valve, and the inherent abnormalities that inherent abnormalities of the tricuspid valve causing tricuspid regurgitation include Ebstein anomaly, right? It includes the Ebstein's anomaly. What is Ebstein's anomaly? It is the distal displacement of the tricuspid valve into the right ventricle. So there will be atrialization of the right ventricle in case of Ebstein's anomaly, right? And the other causes for tricuspid regurgitation include tricuspid valve prolapse, right? Even this can cause tricuspid regurgitation. Next, carcinoid plaque formation, right? Carcinoid plaque formation, then collagen disease inflammation, and tricuspid valve tumors or tricuspid valve endocarditis. Right, tricuspid valve tumors or the tricuspid endocarditis, right? And in addition, pacemaker lead valve injury, right? Pacemaker lead valve injury, even this can cause, and this will be the iatrogenic cause. Right, this will be the iatrogenic cause for the development of tricuspid regurgitation, right? So these are all the other causes of the tricuspid regurgitation, right? So what are the most important causes? It is most commonly secondary to your pacemaker lead placement in the right ventricle. The other causes include the conditions which will cause enlargement of the right ventricle. And what are those conditions which will cause enlargement of the right ventricle? The conditions wherever there is right ventricular systolic hypertension, and that will be there in case of valvular or subvalvular pulmonary valve stenosis, and pulmonary hypertension for any reason, cardiomyopathy. Then right ventricle may also be injured from an MI and may be seen secondary to inherited dilatation, that is right ventricular dysplasia, and right ventricular dilatation often occurs secondary to left heart failure as well. The other causes include the inherited abnormalities like Ebstein's, tricuspid valve prolapse, carcinoid plaque formation, valvular tumors or tricuspid endocarditis, and pacemaker lead valvular injury is an increasingly frequent iatrogenic cause for the development of tricuspid regurgitation. Then what will be the signs and symptoms in these patients with the tricuspid regurgitation? So if you see the signs and symptoms of the tricuspid regurgitation, they are identical to those resulting from right ventricular failure due to any cause. That means these individuals, they will have the features of right ventricular failure. So what will be the features of right ventricular failure? The earliest sign will be, right, the earliest sign will be the raised JVP. Then followed by that, these individuals will have tender hepatomegaly, then pedal edema, next ascites, there can be splenomegaly, and there can be gastrointestinal wall edema, right? So these are the features of the right ventricular failure that can be seen in patients with the tricuspid regurgitation. Next, then followed by that, about the examination findings, that is the JVP. Now what will be the JVP in tricuspid regurgitation? JVP, it is elevated, right? And in tricuspid regurgitation you have the Kussmaul's sign. So what is this Kussmaul's sign? That is increase in the jugular venous distension on inspiration. Right, normally the jugular venous volume should reduce on inspiration, but here in patients with Kussmaul's, they have jugular venous distension, increase in the jugular venous distension on inspiration is called as the Kussmaul's sign. And what will be the waves, right, abnormal waves in the JVP? So abnormal waves in the JVP in tricuspid regurgitation, they are as follows. So there will be reversal of the X wave. See, X wave, it is due to atrial relaxation. And when will the atria relax? The atria will relax during ventricular systole. Right. Now, what will happen in tricuspid regurgitation? Whenever the right ventricle is contracting, the blood from the right ventricle will enter into right atrium during the atrial relaxation. So thereby what will happen to the pressure in the right atria? It is not reduced. So you will have the reversal of X wave. X wave is due to atrial relaxation. That is due to decrease in the pressure within the atria. Right? That is due to decrease in the pressure in the atria. Normal X wave. But here you have reversal of X wave. Why? Because the pressure within the atria is not decreasing during the right ventricular systole. That is the reason why you will have what is called reversal of X wave. Then you have an early Y descent. Right? Why is that you have early Y descent, and what is this Y descent? Y descent tells you about the atrial emptying. Right? Y descent tells you about the atrial emptying. And why is that you have the presence of this Y descent? Why? Because, right? Why? Because in these individuals, there is increased quantity of the blood within the right atrium due to regurgitation. Because right atrium, it receives the regurgitant blood, SVC blood and IVC blood. So there is more blood. So that is the reason why the emptying also occurs early. So there will be an early Y descent that you will have in patients with the tricuspid regurgitation. Then followed by that, you take the V wave. The V wave amplitude is increased. Right? V wave amplitude is increased. So these are the abnormal waves that you will have in tricuspid regurgitation. Reversal of X wave, early Y descent, and as well as the V wave is increased. Next, followed by the, JVP findings, they are very, very important in tricuspid regurgitation. Followed by that, let me discuss the auscultation. Okay, So auscultation, let me tell you, these patients, they are developing right ventricular failure. So you will have right ventricular S3, right? So an S3 may accompany the murmur, right? So on auscultation in these individuals, you also have the presence of a tricuspid regurgitant murmur, and that tricuspid regurgitant murmur, it is a pansystolic murmur, right? It is a pansystolic murmur, and this particular pansystolic murmur, it is heard in the left parasternal area. And this murmur of tricuspid regurgitation increases on inspiration. And there is no radiation of the murmur. Okay. Whereas pansystolic murmur, you will also listen in mitral regurgitation. But whereas mitral regurgitation pansystolic murmur, that will radiate to the axilla. Right, that will radiate to the axilla. So that murmur increasing on inspiration, that is called as the de Carvalho sign. Right, that is called as the de Carvalho sign. So that is about the pansystolic murmur of the tricuspid regurgitation. Next, you need to know that in tricuspid regurgitation, why there is cyanosis. So in tricuspid regurgitation, there is increased right atrial pressure. Right, there is increased right atrial pressure because of the regurgitation of the blood from right ventricle to the right atrium during systole. So this increased right atrial pressure, it stretches the atrial septum. Right, it stretches the interatrial septum. So once this interatrial septum is stretched, then there will be opening of the patent foramen ovale. So once there is opening of the patent foramen ovale, the blood from right atrium the blood from the right atrium will enter into the left atrium through that patent foramen ovale, and due to which the deoxygenated blood will get mixed with the oxygenated blood, and if it is entering into the systemic circulation, thereby the individual will develop the cyanosis. Okay. Next, what are the other features of the tricuspid regurgitation? Severe tricuspid regurgitation, it will result in the hepatomegaly. And it will be a tender hepatomegaly, and when you palpate the liver, you will feel the systolic pulsations over the liver. Right, you will feel for the systolic pulsations over the liver. Right, so severe tricuspid regurgitation results in hepatomegaly. Then followed by that, there is also development of ascites and then the pedal edema. Right, then pedal edema. So these are the features of the tricuspid regurgitation, severe tricuspid regurgitation. Okay. Next, and these are nothing but the features of the right heart failure. Then how will you diagnose? See, diagnosis, definitely the first line investigation will be your echocardiography. So echocardiography, ECG. Next, chest X-ray will help you in the diagnosis. Then confirmatory test will be cardiac catheterization. Right, confirmatory test will be cardiac catheterization. So if you see the ECG, ECG is usually non-specific. What is that you will be able to make out is the presence of the flutter waves. So you can see that sawtoothed pattern of the P wave. So ECG, it can show you the atrial flutter, or there is development of atrial fibrillation being very common. So that will be the ECG changes in tricuspid regurgitation. Then if you take the chest X-ray, chest radiograph may reveal evidence of enlarged right atrium, right? So you can, yes, so that this structure, whatever is dilated, it is your enlarged right ventricle above which you have the right atrium. So you will notice, or the individual will have an enlarged right atrium, and there will be also dilated azygos vein, right, and there can be also development of pleural effusion. So this will be the chest X-ray picture in patients with the tricuspid regurgitation. And then echocardiography. So this will be the first line investigation. So this helps in assessing the severity of tricuspid regurgitation. Right, it helps in assessing the severity of the tricuspid regurgitation. And in addition, echocardiography or Doppler provides right ventricular systolic pressure as well as the right ventricular size and right ventricular function. Okay, so it provides right ventricular systolic pressure, then it also provides right, it also provides the right ventricular size and as well as function. And apart from that, in the echocardiography, you will also be able to make out paradoxically moving interventricular septum, right? Paradoxically moving interventricular septum may be present due to volume overload of the right ventricle. Okay. Right, paradoxically moving interventricular septum may be present due to volume overload of due to volume overload on the right ventricle. So that is about the echocardiographic picture in patients with the tricuspid regurgitation. So number one, it will assess the severity of tricuspid regurgitation. In addition, echocardiography or Doppler provides the right ventricular systolic pressure as well as the right ventricular size and function. And you will also able to make out paradoxically moving interventricular septum may be present due to volume overload on the right ventricle. Then followed by that, the cardiac catheterization. See, cardiac catheterization definitely, right, this will definitely confirm the presence of the regurgitant wave in right atrium and elevated right atrial pressure. So this will confirm the presence of will confirm the presence of regurgitant wave in the right atrium, and it will also confirm that there is elevated right atrial pressure. Okay, next, then followed by that, the next important is the treatment. So if you take the medical management in these individuals, mild tricuspid regurgitation is common and generally can well managed with the diuretics. Okay, so if the individual is having mild tricuspid regurgitation, it is generally well managed with the diuretics, right? When severe tricuspid regurgitation is present and when there is development of bowel edema, this bowel edema can be reduced by your diuretics such as the furosemide and bumetanide and as well as torsemide. Okay, so when there is severe tricuspid regurgitation, there is high chance of development of the bowel edema, right? There is high chance of development of the bowel edema, right? This bowel edema, it will reduce the efficacy of, right, will reduce the effectiveness of diuretics such as furosemide. Okay, so the efficacy of the furosemide is reduced if you give it orally in the presence of the bowel edema. You have to give furosemide only through the intravenous route, right? Only through the intravenous route. And in order to reduce this bowel edema, what are the diuretics that can be given safely is torsemide and then bumetanide. So these drugs, they are better absorbed right, they are better absorbed in this situation when oral diuretics are added. So these are the one which have a good absorption even though there is presence of the bowel edema. So that is about your diuretics. And the other important thing is the aldosterone antagonist. And these aldosterone antagonist, example spironolactone. Spironolactone have role as well, particularly if ascites is present. Right, particularly if ascites is present, then you need to give this aldosterone antagonist, that is spironolactone. And at times, see, if you want to increase, right, if you want to increase the efficacy of thiazide diuretics, if you want to increase the efficacy of loop diuretics, to this loop diuretics, you need to add thiazide diuretics. Right, to this loop diuretics, you need to add the thiazide diuretics. So the efficacy of loop diuretics can be enhanced by adding this thiazide diuretics. Right, by adding this thiazide diuretics. Okay, this is a very, very important point. And most tricuspid regurgitation is secondary. Definitive treatment usually requires elimination of the cause of the right ventricular dysfunction. Okay, so the next important thing is you need to treat the cause of right ventricular dysfunction, because it is the right ventricular dilatation which is causing tricuspid regurgitation. So you need to treat that underlying cause. Then followed by that, surgical treatment in tricuspid regurgitation. Surgical valve replacement in secondary tricuspid regurgitation is rarely, if ever, indicated until the cause of right ventricular dysfunction is resolved. And if the problem is left heart disease, then treatment of left heart issue may lower the pulmonary pressure and reduces the right ventricular size, and it will resolve the tricuspid regurgitation. Right? And where is that you will require the surgical valve replacement is whenever there is primary pathology. Right? Whenever there is primary pathology. Okay. So in primary valve disease, you need to do the surgical treatment. And what will be that surgical treatment? That is annuloplasty, that is repair. Right? So primary valve disease, or whenever there is right ventricular dilatation, and this right ventricular dilatation you have treated initially with medical management, stands for medical management, but the individual is refractory to medical management, that is the point when you need to do surgical treatment. Right, that is the point when you need to do surgical treatment. So you need to do what is called annuloplasty, right, repair of the annulus. So annuloplasty without insertion of the prosthetic ring. And what is this annuloplasty called? That is de Vega annuloplasty. Right, de Vega annuloplasty. This also is considered to be effective in reducing the tricuspid annular dilatation. Right. So that is about the surgical treatment. So surgical treatment, that is for primary valve disease and as well as the secondary disease, that is secondary to your right ventricular dilatation. But here we give medical management first, but if the individual is refractory to medical management, then we do the surgical treatment. And what is that? That is annuloplasty, repair of the tricuspid valve annulus. That is by de Vega annuloplasty, right? That is effective in reducing the tricuspid annular dilatation, right? And for suppose, if there is an inherited defect in the tricuspid valve apparatus that cannot be repaired, then replacement of the tricuspid valve is warranted, right? Replacement of the tricuspid valve is warranted. Now, you need to decide between the bioprosthetic or the mechanical valve, right? So this bioprosthetic valve, it is more preferred. Right, it is more preferred than compared to that of the mechanical valve. Okay, so a bioprosthetic valve rather than mechanical valve is almost always used because of the risk of mechanical valve thrombosis. See, the problem with the mechanical valve is there is risk of thrombosis, right? And because of the risk of thrombosis, you need to give the anticoagulation, right? You need to give anticoagulation. And whenever you are giving the anticoagulation, there is chance of bleeding in the other areas of the body. Whereas anticoagulation, it is not required. Right? Anticoagulation is not required in case of bioprosthetic valves. Why? Because the risk of thrombus formation over the bioprosthetic valve is less. Okay, so that is the reason why anticoagulation is not required for bioprosthetic valve. But in which scenarios of bioprosthetic valve you require the anticoagulation is unless there is associated with atrial fibrillation, right, associated with atrial fibrillation or the atrial flutter. So, in these scenarios of the bioprosthetic valve, you need to do or you need to give the anticoagulation. Otherwise, in the bioprosthetic valve, you don't give the anticoagulation. Right? And let me tell you, the tricuspid regurgitation due to bioprosthetic degeneration has been shown to respond to transcatheter valve replacement. So, you have put a bioprosthetic valve, but due to degeneration of the bioprosthetic valve, there has been development of tricuspid regurgitation again. Then how will you treat that? That is by transcatheter valve replacement. Okay, but this percutaneous tricuspid valve replacement for native valve tricuspid regurgitation, it is being successful in some of the reports. So, This transcatheter tricuspid valve replacement, it is useful for bioprosthetic degenerated valve causing tricuspid regurgitation, and as well as in case of native valve tricuspid regurgitation, some reports are there which has been shown to be success. Okay, next. So this completes the discussion of tricuspid regurgitation. So what will be the etiology causing tricuspid regurgitation? Mainly either the pathology in the valve or due to dilatation of the right ventricle. And the features will be similar to that of your heart failure. And the examination findings, JVP, there will be elevated JVP, Kussmaul sign, reversal of X wave, early Y descent, V wave amplitude or V wave is increased. And on auscultation, you have the presence of a pansystolic murmur. And investigation, the first line investigation will be echocardiography. The treatment, mild cases do or give the diuretics. Whereas in severe cases, that is the place where you need to do the surgical treatment. Okay. Now, you see a question. The most common cause of tricuspid regurgitation is secondary to rheumatoid heart disease, dilatation of right ventricle, coronary artery disease, endocarditis due to IV drug abusers. So, that is due to dilatation of the right ventricle. So, this tricuspid regurgitation, let me tell you, you can have either functional tricuspid regurgitation, right, and it could be due to pathology in the tricuspid valve itself. Functional tricuspid regurgitation is what? That is nothing but your dilatation of the right ventricle, right? That is what is your functional tricuspid regurgitation. Next, hepatomegaly with liver pulsations indicates tricuspid regurgitation, mitral regurgitation, pulmonary hypertension, mitral stenosis. So, hepatomegaly with liver pulsations indicates the tricuspid regurgitation. And what is that pulsations you will have in the liver? That is right, that is systolic pulsations. So, systolic pulsations of the liver and marked hepatomegaly, their characteristic features. And why is that you have systolic pulsations? Because the regurgitation of the blood from right ventricle to the right atrium occurs during systole. So, during systole, the right atrial pressure is increasing and that will reflect back onto the liver, and that will be in the form of the systolic pulsations. Okay, right. Now, you see this Carvalho's sign. Carvalho's sign is seen in tricuspid regurgitation, mitral stenosis, aortic regurgitation. Let me tell you, Carvalho's sign is that increase in the amplitude or increase in the intensity of right-sided sounds, right? Increase in the intensity of the right-sided sounds on inspiration is called as the Carvalho's sign, right? And you will have that in tricuspid regurgitation. And what is the only sound which will not increase on inspiration, which is a right-sided sound? That is the pulmonary ejection click of pulmonary stenosis. So, please remember, pulmonary ejection click of pulmonary stenosis will not increase on inspiration, right? Next, then we have Whitem sign. Whitem sign, where do you see? Tricuspid regurgitation, MS, AS, AR. Whitem sign is seen in patients with the tricuspid regurgitation. And what is Whitem sign? Whitem sign is increase in the intensity of murmur, right? Increase in intensity of murmur on pressing the liver, right? Increase in intensity of murmur on pressing the liver is called as the Whitem sign, right? Next question. Next question is most common valvular lesion seen in carcinoid syndrome. Tricuspid stenosis and pulmonary stenosis, tricuspid insufficiency, pulmonary stenosis, mitral stenosis, aortic stenosis, mitral insufficiency and aortic stenosis. So, please remember, in case of carcinoid, it is right-sided valvular pathology. But what is that right-sided valvular pathology? That is tricuspid regurgitation and pulmonary stenosis. So, this will be the most common valvular lesion seen in the carcinoid syndrome. So this completes the discussion of the very important topic, that is tricuspid regurgitation. Thank you very much.